come now to the colon, and Professor Yahagi will help us to describe and classify colonic lesions in order to make a decision what we should do.
Thank you very much, Stefan, for inviting me to a wonderful endoscopy course again here in Zurich. It is always my great pleasure attending this course. Well, as everybody knows, during the screening colonoscopy, we have to detect target region, basically using white light image. Then, if there is some suspicious region, we have to assess the region very precisely before deciding our treatment option. Basically, target region should be detected by white light image, looking at the surface of the target area, look for the certain irregularities such as slight elevation, slight depression, or redness of the color, or disappearance of the vascular network. Then, if you find some suspicious area, we have to evaluate it. Now you can see the irregularity of the mucosa here, so you can easily identify this lesion. But if you carefully look at this area, you can recognize the disappearance of vascular network, but still you are not sure what the lesion size is. In this particular situation, we usually use NBI magnification or indigo carmine dye spraying. Basically, indigo carmine dye spraying is very simple but very useful, effective technique for the demarcation of the target lesion. This is white light image again. Then, if we spray indigo carmine, it turns to be very clear. Surprisingly, this region was already spreaded nearly half circumferentially. So we had better to spray diluted indigo carmine if you find some suspicious area. That is very effective. Then we can use NBI magnification for the characterization of the target lesion. I think Sano's classification is very popular already. And in case of having non-meshed capillary vessels, it usually suggests hyperplastic polyp or normal background mucosa. And if you can find meshed capillary vessels, usually it suggests benign lesion such as adenoma. And if the meshed capillary network becomes slightly irregular, usually it suggests mucosal cancer or intraepithelial, I mean high-grade dysplasia. Then, if the vascular network becomes highly irregular or avascular, it usually suggests deep submucosal invasion. But in case of using Sano's classification, it is necessary to use magnification function. Unfortunately, at least in the past, most of you doesn't have any magnification function for the daily practice. Therefore, some of the European experts working together with Japanese experts developed nice classification, and they make a little bit simple classification divided into 3 groups. If the surface structure still keeping normal vascular network and surface structure keeping the regularly arranged network, it suggests normal background mucosa. And if the surface structure becomes a little bit irregular, it usually becomes mucosal cancer or adenoma. And of course, if the surface structure becomes highly irregular or amorphous, it suggests deeply invasive cancer. But still, it was very difficult to characterize the target lesion using nice classification because sometimes endoscopic image was not good enough. Therefore, after launching our Olympus latest endoscope, which we can use near focus mode, we again switch back to the NBI magnification because we can characterize the target lesion more detailed. Currently, Japanese NBI expert team already working for the new classification, which is JNET classification. This is more detailed classification for the characterization of colonic lesion. As I mentioned, if the vascular network is relatively regular and surface structure is also very regular, it suggests the benign lesion. And if it becomes slightly irregular, tortuous structure, it suggests cancerous lesion. And if it becomes completely irregular or avascular amorphous, it usually suggests deeply invasive cancer. Therefore, we usually don't touch this kind of type 3 cancerous lesion. That is very important. So back to my presentation. If the target lesion judged to be small adenoma or small mucosal cancer, which is good enough for snaring, we can simply remove this lesion by standard EMR, such as this lesion. This is regularly arranged surface structure having the nice vascular network, which is classified JNET type 2A. This is a typical appearance of benign adenoma and very small, less than 2 centimeters. Therefore, we easily removed by standard EMR. But in case of having much bigger lesion or small region but having some suspicious area for submucosal invasion, we have to further characterize those regions using crystal violet staining magnification. As everybody knows, the pit pattern classification developed by Professor Kudo is much powerful to estimate the depth of tumor invasion. Most of the benign tubular adenoma looks type 3L, and most of the cancerous lesion is classified as type 5I. And in case of having slightly irregular type 5I pit pattern, it tends to be mucosal cancer. But in case of having non-structured type 5 pit pattern, it usually suggests the deep submucosal invasion. Actually, according to Professor Kudo's publication, if the target lesion presents type 3L, most of the target lesion is still benign adenoma. 95% of lesions are still benign. But in case of having type 5I, irregular type 5 pit pattern, 80% of the lesion already become cancerous lesion. And of course, in case of presenting non-structured type 5 pit pattern, 95% already become invasive cancers. So this is a very important take-home message. So after the precise evaluation using crystal violet staining and magnification, and if the target lesion turns to be large superficial lesion, most of the endoscopists still prefer to do piecemeal resection. But there is one surprising case report which was reported by National Cancer Center group. This was a very large superficial lesion located at the lower rectum. They precisely evaluate the target lesion using crystal violet staining and magnification. And most of the target lesion are still having nicely arranged type 3L pattern, but some part of this region becomes slightly irregular type 5I. So they judged this lesion was a mucosal cancer, so they conducted piecemeal resection. It was nicely removed, of course, and clinical course was quite good until 1.5 years later. But surprisingly, 2.5 years later, it was recorded as a deeply invasive cancer. So, of course, it required surgical treatment. This is quite a rare case, but sometimes this kind of local recurrence happens after the piecemeal resection. And unfortunately, local recurrence after the piecemeal resection is quite high, which is more than 20%. Therefore, I myself prefer to do ESD even for the mucosal cancer if the lesion size is relatively large. So this is a large laterally spreading tumor with granular type, which was located at the lower rectum. and it was already embedded to the anal canal. We carefully evaluate this target lesion, and most of the surrounding mucosa showed JNET type 2A, which corresponding to the benign lesion. But some of the protruded area showed slightly irregular surface structure and irregular vascular network, which classified JNET type 2B, suggesting cancerous component. Again, we conducted crystal violet staining and magnification. Most of the surrounding tissue showed regularly arranged type 3L pit pattern, but as I mentioned, some of the lesion already changed to the cancerous component. That's why it looks slightly irregular type 5I pit pattern. So we decided to do ESD because we judged this as a mucosal cancer. Actually, it was a 13 centimeter mucosal cancer. Of course, there was some benign adenoma component remaining at the surrounding tissue. Clinical course after the complete resection by ESD was quite favorable. There was no severe stricture at all. This is the beauty of ESD technique. And in case of having suspicion of deep submucosal invasive cancer after evaluating target lesion using crystal violet staining and magnification, we sometimes conduct EUS to confirm the real depth of invasion. This is such a case. This is a really tiny protruded lesion located at the rectum. Probably lesion size was just 1 centimeter in the greatest diameter. It looks very easy lesion for the snare pulpectomy or EMR because of the small lesion size. But carefully look at the surface using NBI and magnification, you can easily recognize this diluted neoplastic vessel. Then you can recognize a vascular area here. This is a typical appearance of deeply invasive cancer, which is classified JNET type 3. And again, crystal violet staining magnification showed as highly irregular type 5I pit pattern, which also suggests invasive carcinoma. Because of the small lesion size, we conducted EUS before sending this patient to surgery, and EUS finding also suggested a deep submucosal invasion. Therefore, we conducted surgery, of course, and actually it was deeply invasive submucosal cancer. Well, after the EUS, if the target lesion turns to be mucosal cancer or slightly invasive submucosal cancer, it is a really good candidate for ESD. This is, again, a relatively large laterally spreading tumor with mixed type located at the rectum. And as you can see here, there was a big protruded area within the lesion. And unfortunately, central part of the protrusion already becomes depressed, which is typical appearance of invasive cancer. So we imagine that this was already becomes invasive cancer, but carefully look at the surface structure using chromoendoscopy. Still, we recognize some regularly arranged surface structure. I'm sorry, I forget to include the NBI image, but even with NBI image, we could recognize the nice surface structure. Then we conducted crystal violet staining, and most of the pit pattern shows type 4 pit pattern, which suggests tuberous adenoma. But because of the irregular shape of this big protrusion, in order to make it sure, we conducted EUS, and the EUS fortunately didn't show any deep submucosal invasion. That's why we conducted ESD. And the final result was just a mucosal cancer sized 9 centimeter in the greatest diameter. So this kind of diagnostic and treatment strategy is very important for everybody. Thank you very much for your kind attention.
Thank you very much. I have a question for us Europeans. Always the question that when we found a polyp, it takes a lot of time. We are not really taught how to do the staining. Then the discussion takes a lot of time. How do you proceed with regular polyps? Some arguments also, we cannot stain all polyps, how to go. So we have now available high magnification endoscopes. We have NBI. When do you still use the Indigo carmine, and when do you still use crystal violet in the daily clinical practice?
Most important thing is to clean the lumen and the surface of the target lesion before evaluate the target lesion. I had many chance to visit European institution and American institution, and surprisingly, they try to evaluate target lesion without washing the target lesion. It means that within the dirty situation, they try to use NBI or chromoendoscopy. I think it's nonsense. It is very important to clean the lumen and clean the surface of the target lesion before starting actual inspection. That is first message. Then we can use NBI. It's very simple, just switching on NBI. And if there is some irregularity and suspicious area having neoplastic lesion, I usually spray Indigo carmine. Indigo carmine is also very simple technique, just spray diluted in Indigo carmine. Then if I found really irregular mucosal surface or irregular vascular network with NBI and magnification, I definitely perform crystal violet staining and magnification. If on the contrast, if there is no irregular vascular network and most of the surface structure still keeping regularly arranged structure, I usually don't perform crystal violet staining and magnification.
And another question for us, the question is sometimes because colonic ESD is very difficult for us, especially in the Western world, how high is your rate of successful decision making? So if you have decided for surgery, not for ESD primarily, do you have any cases where you made the wrong decision?
I think wrong decision will be less than 5% of all surgically treated cases, but still nearly 5% of the surgically treated cases still remaining within mucosa or shallow submucosal layer, which might be curatively dissected by endoscopic means.